Good afternoon, everybody. I'm Sarah Dash, President and CEO of the Alliance for Health Policy, and I want to welcome you to week 4 of our COVID-19 webinar series. For those who are not familiar with the Alliance, we are a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. We launched this series to provide insight into the status of the COVID-19 response and shed light on remaining gaps that must be addressed to limit the severity in the United States. The Alliance gratefully acknowledges the National Institute for Healthcare Management Foundation and the Commonwealth Fund for supporting our COVID-19 webinar series. You can join the conversation on Twitter using the hashtag AllHealthLive and follow us at AllHealthPolicy. We want you to all be active participants, so please get your questions ready, and here's how you do it. You should see a dashboard on the right side of your web browser that has a speech bubble icon with a question mark. You can use that icon to share any technical issues you might be experiencing, as well as to submit questions for the panelists at any time during the broadcast. Finally, check out our website, allhealthpolicy.org, for background materials and a recording of today's webinar, which will be made available soon. Today, I am so pleased to be joined by Dr. Mark McClellan to discuss steps that policymakers can take to speed the development and evaluation of medical products to track, treat, and prevent COVID-19. Mark is the Robert J. Margolis Professor of Business, Medicine, and Policy and founding director of the Duke-Margolis Center for Health Policy at Duke University. He earlier served as Commissioner of the U.S. Food and Drug Administration and Administrator of the Centers for Medicare and Medicaid Services. Mark, thank you so much for joining us today. I'm going to start with an opening question, and again, for the audience, if you have questions, just share it at any time, and we'll do our best to weave it in. Okay, Mark, so social distancing measures are in effect in most, though not all, parts of the country. The healthcare system is bracing for a surge in cases. I want to start by asking you to help us to look ahead. What can policymakers, private sector do now to reverse the trajectory of the virus and set up an infrastructure for tracking, testing, treatment of COVID-19 so that we can safely return to some degree of normalcy?
Well, first off, Sarah, thanks to you and the Alliance for being such an important resource at a challenging time. The Alliance has always been great for keeping policymakers up to date and supporting effective legislation on a wide range of healthcare issues, but we really need this now. So it's a pleasure to be on with you and so many of your listeners. You're right that this is the way pandemics start. It always, by definition, you don't have any effective treatments. Sometimes you only know what the agent is, and so the main things, the critical things to do are all about physical distancing and isolation, and we've taken those measures like the rest of the world to a pretty extreme and unprecedented level. I agree, we're probably not doing all that we could in all parts of the country to prevent this initial spread of the virus, and as a result of that, we're seeing the peak now in many parts of the country, and in others it may well come later. It's not like any part of the U.S. is immune to the threat of COVID-19, and people are understandably focused on getting through this really horrible situation with so many deaths and so many people affected. But you're right that we will get beyond that. We've already got a number of diagnostic tests that are available. Those are going to keep getting better, both for identifying who has an active infection and, increasingly important, who's been previously exposed and may now be immune. That's going to help with moving beyond where we are now. We talked about in a previous report that Scott Gottlieb and some of our collaborators issued through the American Enterprise Institute about a week ago, a pathway to reopening that puts a big emphasis on using better diagnostic tests to get ahead of the epidemic to the point where we can actually identify any new outbreaks early and do contact tracing using this much expanded diagnostic test capacity to contain the epidemic and avoid big surges like what we're experiencing now. We never want to live through that again. But the real ball game is about the treatments, and the eventual solution to this is probably going to be a vaccine or multiple vaccines that help people become immune at a broad enough level in every community that the virus just can't effectively spread and have an impact, but that's going to take a while. So in the meantime, there's some very promising treatment options in development. Some of this is just what clinicians are learning as they take care of more patients. What's the best way to support an individual with an advanced respiratory problems, the best way to ventilate, things like that. We'll learn more about that. And especially, how can we bring effective treatments to bear in the shorter term? So that'll include so-called antiviral drugs, including both existing drugs that may have activity against the virus and new drugs like Gilead's remdesivir that slow down viral replication or keep it from having as much of an impact on the person who's infected. There also are immune-based therapies in development. People have heard about now with a growing number of individuals who have recovered from COVID-19 infection about the possibility of using serum from these individuals, which contain immune globulins that can potentially successfully fight off the infection, so-called convalescent serum. We're still learning about whether and how that works. It hasn't always been slam dunk successes in previous infections, so important questions to answer there too. But then new technologies that enable monoclonal versions, just synthetic, rapidly manufactured versions of antibodies against the virus. So those are in development too, and potentially important type of treatment. And then a third category is drugs for very seriously ill patients who seem to, in many cases, have an intense immune response that goes beyond fighting the virus and starts damaging the lungs and other parts of the body. And this overreaction is something that so-called immune-mediating drugs, that's different than antibodies, but immune-mediating drugs may be able to help with. So some of those are in development as well. And the real challenge for policymakers and the clinical community is how do we learn which of these treatments work as quickly as possible? It's not just a matter of trying to make available treatments that may work, but really learning about quickly and under these very difficult circumstances, which ones are really going to make a difference.
Thanks, Mark. That's a great overview, and it's really kind of amazing that just in this relatively short time period, we already know so much about the different kinds and different categories of drugs that might work and treatments that might work. But tell us, so you ran the FDA and CMS. You've written white papers on this topic with Scott Gottlieb and others. Tell us what kind of infrastructure is needed to really answer that question about how we know what works and what's safe, what's effective. How do we parse through all of this, and what kind of infrastructure is needed at the federal and other levels?
Well, we've got some good models. Scott and I called for really an intense effort to take those existing models and bring them to a different level of intensive activity, just because so much is at stake in terms of health and economic impact of this virus. It really deserves an unprecedented level of attention. A lot of that is happening. So the FDA has many established programs to work closely with product developers who are working on new kinds of treatments, especially smaller companies who may not have, biotech companies who may not have that much experience with the development process. And a lot of people think of FDA as being like a gate check at the end, where, okay, how long is it going to take to review an application and get it approved? But that's really the wrong way to think about the way the development process works. There are many steps that need to happen to get to safe and effective evidence the product is safe and effective, that can be accelerated. This can happen through things like close consultation with the FDA. They have so-called breakthrough programs and other programs to interact extensively with companies that are thinking about how to design studies, how can they get as quickly as possible to study results based on not having to do necessarily a very large study, but just a very well-designed study. There's lots of expertise that the agency can bring to bear. Also very important is federal funding to help support these efforts. That can come through the National Institutes of the National Institute of Allergy and Infectious Disease, and also an agency called BARDA, which does advanced research and development for medical countermeasures. It's part of the Assistant Secretary for Preparedness and Responses Office. So those organizations have been helping and pumping in additional resources to start getting testing underway and to hopefully conclude it to the point where you can see that a treatment is really safe and effective in the shortest amount of time possible. Also, though, it's not just a matter of proving that a treatment works or getting good enough evidence that a treatment works. There's also a challenge of manufacturing. So many of these biologics involve complex processes, again, especially if small companies are involved. They may not be ready to scale up, and it can often take months after a drug is approved for the manufacturing facilities to come online and be certified. And so there are also important steps underway now to basically try to do the manufacturing processes at the same time as you're doing the studies to show the treatment does work well enough to be approved and made widely available. But Sarah, here's the challenge in all of this, is that because there are so many urgent unmet needs for treatments, there is an intensive pressure and understandable pressure to make these treatments available even before we have very good evidence on whether they work. And hydroxychloroquine is an example I think many people who are listening today are familiar with, where there was a very limited amount of evidence before, not evidence that I personally think is compelling enough to encourage people to use this treatment broadly. But there has been a lot of demand for the drug, and that's complicated getting some of these studies done. So something else that Scott and I called for in our approach to this problem was making sure that there's a good process for emergency access for people who don't have any alternatives and want help, but that there's at the same time a really efficient way of getting the clinical study evidence that's needed. And I think looking ahead, we're probably going to see a few treatments that will show some promising evidence, not just hydroxychloroquine, but some of the other types of drugs that I mentioned. And there's gonna be a lot of pressure to make those available for broad emergency use. So looking ahead, since COVID-19 patients are diverse, there are many different uses for potential drugs, ranging from prophylaxis to treatment of early uncomplicated cases to treatment of the most severe patients. It's going to be important to set up ways to learn more about these treatments when they're on the market. And that's something where payers like CMS can make a difference, where healthcare providers that are part of clinical research networks to develop so-called real-world evidence can make a difference. And I see those being important issues in the coming weeks as we get more treatments that look like they may work, to really understand how to use them as well as possible, as effectively as possible. And the more of these treatments where we can develop that good evidence, the better positioned we're going to be to actually really affect the course of this epidemic.
Thanks, Mark. And you already anticipated one of our audience questions about hydroxychloroquine and whether the evidence is sufficient. So I want to ask you to just follow up on this question of emergency access, as well as getting the efficient clinical evidence that we really need. Can you put a little bit of a finer point on that? Like, what are some of the steps to putting that process in place?
So one step is that tight collaboration between FDA, the product developers in the private sector, NIAID, and BARDA, among other groups, to make sure that the most promising agents are getting into clinical trials that are well designed, and what we say in the lingo is well powered. That means they have enough patients involved, they're collecting the right data to answer questions about key endpoints on effectiveness and safety. We need to make sure that those trials are really being done as quickly and efficiently as possible, because again, the world doesn't want to wait. They want access to treatments that even might work if there's nothing else available. So continued attention to that, and policymakers asking the question, well, of all the top 20 or 30 or 50 drug candidates? Are all of them in trials that are on track for completion rapidly? Are all of them in trials that have enough enrollment and that are well designed using these good clinical study principles? So that's one important part to watch. But the other, for a treatment like hydroxychloroquine, that's it's already on the market, it's an existing drug, we've seen what happens. So there's now shortages of the drug, understandably, as lots of people are trying it. There are people who have conditions like serious diseases like lupus who are now having trouble accessing it, and this is a condition where the drug has been proven to be safe and effective. And not only are there questions about the effectiveness of hydroxychloroquine, but there are also questions about the safety, particularly for people who have heart disease and might be using it, as some have suggested, with an antibiotic called azithromycin that together can cause irregular heart rhythms and serious problems. So this is actually happening now. My hope is that the clinical trials, the clinical studies that are being done in the real world will provide good answers about the impact of hydroxychloroquine in the coming weeks. A good example of one is a trial called HERO that my colleagues at Duke, at the Duke Clinical Research Institute, are helping to lead. That involves by smartphone enrollment, a lot of frontline healthcare workers around the country. That's a great way to get good evidence in the real world in this tough situation that we're dealing with. My hope as well is that as other treatments come to market, and my guess is, again, they're going to come to market with some evidence but not great evidence, that we'll find a way to both learn more about them through practical real-world studies like I just mentioned, but they'll also do a good job of tracking safety. I understand there already are a number of reports of adverse events happening, again, for people who have heart problems and the like who are using hydroxychloroquine. So this is where this is the difference between getting out of this epidemic fast and getting out of it slower. The attention to getting good clinical evidence quickly under a very challenging real world situation where people want access to treatments that might work. We at the same time have to pay a lot of attention dealing with that reality to developing the real evidence on which treatments do work. And especially since, it doesn't look like we've got a magic bullet yet. Hopefully one of these treatments coming along will just work so well, people will just get up and leave the hospital or not develop complications. I wouldn't count on that. I think we've got to count on the need to try out a lot of these treatments quickly, and again, get real evidence, not just hope for the best with emergency use only.
Thanks. So there are a couple of audience questions that pertain directly to this. So one is whether you can discuss the timeline for getting these novel therapeutics. First of all, obviously, to the evidence, but then to get them to a large number of patients or to the right patients. Are there things that FDA and others can do to accelerate the approvals, as you said, safely and with good evidence?
Yeah, there are a number of steps. I've mentioned a lot that FDA is taking for any, for any manufacturer that is developing a new treatment. They need to be working closely with FDA and these other experts in government around funding and around supporting effective trials as early as possible. And I think an important, from the policy side, thing to track is just how many well-designed trials are being run. What is their expected date of completion? And have we really done all that we can to enroll enough patients and design the trials well so that time comes as soon as possible? There are a number of groups, including that we're collaborating with, that are trying to help with this effort. Faster Cures with the Milken Institute has a nice clinical trial tracker that they're trying to expand and make richer to include these key elements, like how well is the study going in terms of enrolling enough people and getting to completion. There's work being done by a group called the Clinical Trials Transformation Initiative, also part of Duke, that is helping to develop more standard ways of doing clinical trials in the COVID-19 era. So if we could create a platform, sort of a typical approach that any new product developer might use, hopefully there'll be a lot of clinical organizations willing to raise their hand and participate in those studies. So a network supported by standard, efficient approaches for doing these trials. A lot of work going on this, but I don't think we're all the way there yet. And then also very important with the key question about, we're actually going to be able to get the treatments to the people who need them. Remember that when these treatments become available, either with emergency use access, like for hydroxychloroquine or for some of the other drugs that do go through these trials, there will be a lot of unanswered questions, maybe about different populations, people in different subgroups, older individuals, those with other conditions or ethnic backgrounds, where we're just not going to have great evidence at the time that they get to market. And that's why it's so important, I think, for payers to be involved in supporting using the data that they collect from claims and working with health systems that have good electronic records and that can potentially participate in these clinical study networks to help make sure we're learning more about the treatments that are on the market. And this attention to real world evidence for the treatments that do make it to market, either through emergency use or with some initial indications for approval, is another area where I hope we can see some more policy attention and some more steps from the private sector, healthcare organizations and payers as they come out of this surge right now. This is a key part of the response and getting the epidemic under control as quickly as possible.
That's great. And let me ask you a couple more collaboration questions, because we've had some more come in from the audience. So one has to do with international collaboration. How can international collaboration help us? And in particular, somebody asked about the World Health Organization's Solidarity Trial, which pools data from clinical trials and 4 different treatments from around the world. How can international collaboration help us? And then I'll just tack on, philanthropic collaboration. The Zuckerberg Foundation and the Gates Foundation are teaming up to try to accelerate finding treatments that work. Talk about how that works.
Yeah, so great question. So everything I talked about in terms of the importance of designing clinical studies efficiently and in a way that deals with the reality of a real world where there's going to be a lot of pressure for just access to drugs, even when the evidence is limited. It's the same principle at the global level as what I was talking about for the United States. So the WHO has worked with the National Institute of Allergy and Infectious Disease and with the FDA and other regulatory agencies, I believe, to try to encourage the use of a common, efficient approach to doing these trials so that everybody doesn't have to reinvent the wheel. And so then it becomes easier, as you said, like in the Solidarity study, to pool data across sources, to add in new drugs as evidence suggests that some of the ones that are being tested now aren't that useful. Well, let's not try to have to start a whole new clinical trial from scratch. Let's just plug those drugs into this existing network. So absolutely, the same principles I talked about at the US level are important at the global level. One other issue that's very important for global public health is, we can't forget this epidemic will not be under control and the US will not be protected until there's control and protection throughout the planet. And so not only do we need to develop good evidence, but we really need to be thinking ahead about availability of the treatments that work. So I'm very pleased to see some efforts, like one supported by BARDA and some of the companies that are involved in manufacturing vaccines, to not wait until the clinical studies are done to start planning for and ramping up major manufacturing capacity. And I think that's an area where more global collaboration and support from the US would be really helpful. And with respect to the foundations, it's great to see. There's now billions of funding literally coming in from all kinds of philanthropic sources around the country and around the world to try to test out new therapies. It would be great if that funding can be integrated into these networks too. Everybody wants to help. and everybody wants to do it quickly. If we can help foundations like Chan Zuckerberg plug into some of these clinical trial networks and coordinate on the studies that they're doing so that they don't overlap with and they really complement studies that are being done by other organizations, that'd be really helpful. It's hard to do at a time like this when everybody is under so much time pressure for action, but I think it would really help make sure that all this foundation support goes to trials that are well designed, that are efficient, and they're going to really help maximize and leverage those funds to develop better, to let us know what we need to know about whether these treatments really work.
Thanks. Well, in the time we have left, we spent a lot of time on treatments, which is super important. I want to make sure we get a chance to talk about testing and to some extent, vaccines as well. Talk about your thoughts there. At what point are we going to have enough capacity to test a large enough part of the population? Can you talk a little more about the serologic testing? What are the big important next steps around testing, around surveillance, and around vaccine development?
Yeah, so we need to get to a national COVID-19 surveillance system in this country as quickly as possible, along with colleagues, including Scott Gottlieb and others, Farzad Massashari, Caitlin Rivers, and Lawrence Silvis. And we have a report coming out shortly, I think tomorrow, on a lot of detail on what we think is needed for an effective surveillance system. I think we're getting there in terms of testing capacity for whether or not people are infected with the virus, and we have a lot of steps described in this report to make sure those tests are done on the right people. The information is shared electronically rapidly, and we really get from where we are now, which is some pilot efforts around the country to start to try to do testing everywhere it's needed and do the needed contact tracing, something that's much more systematic and backed by the CDC with funding and also supported by payers to not only do the right testing but report the information. On the other side of testing is so-called serologic tests. These are tests for exposure and whether or not someone is immune, has a strong enough immune response to the infection that they won't get it again. Those tests right now are coming to market fast with, again, emergency use authorizations, and they can be quite helpful in determining just how widespread COVID-19 has been in our communities. I think it's a lot wider spread than most people are aware of based on the positive tests so far, but we just don't know. We need to figure that out quickly. It's very important for future planning. There is still work to do, though, on those serologic tests to make sure that they're quantitative enough and accurate enough to give people confidence about when they get a certain test result that they really are immune. And that's an area, too, where we need, back to the same theme, more real-world testing. So the tests are going to be out there. They've been emergency authorized for use to identify people who may have been exposed. To take it to the next level and be confident about whether they're actually immune, we need to do some further testing in practice, in the real world, on how reliable those tests actually are. And the sooner we can do that, the sooner we can get this piece of the response taken care of.
Thanks, Mark. Well, there is so much more to talk about, and I want to acknowledge that there have been a lot of audience questions coming in. You've answered a lot of them. Some of them we haven't gotten to. I want to invite our audience that if you have additional questions to contact the Alliance, and we will do our best to answer them in future webinars. Mark, before we close, I just want to ask you just real quick, what's the thing to look for in the next week?
I think you're going to start seeing in the coming weeks more emergency access to other potentially beneficial treatments. So this will start to look better, but again, the follow-up question you should ask is, do we really know if these treatments work well enough to be used widely, and how can we learn more quickly in this very messy setting of a rapidly developing real-world epidemic? The other piece, hopefully, Sarah, will be some good news in terms of moving past this really tough surge that the country is living through. We're not through the hospital surge yet by any means. We're not even there in many parts of the country, but it does look like these intense social distancing steps, physical distancing steps, are working, and that gives us a foundation. If we take the further steps we've talked about, a really good surveillance system and really good steps to accelerate evidence on promising treatments and hopefully before too long a vaccine, to really recover from this epidemic. So some good things to look ahead to in what's really a extraordinarily difficult situation.
Well, we will be keeping our eyes peeled for those developments. Dr. Mark McClellan, thank you so much for joining the Alliance for Health Policy today. Thank you for answering our questions. We are incredibly grateful, and we will be posting some of the resources that you mentioned on our website, and hope we can talk again another time.
All right, great to be with you, and best wishes to everyone who's working so hard on responding to the COVID-19 pandemic.
Thank you.